Module 4C. In this module, we will be discussing communication skills training. When you notice that a patient may have difficulties with their communication skills to the extent that it interferes with their functioning, it may be beneficial to include this as a goal for therapy. Communication skills and other social skills deficits can arise due to not having appropriate modeling or exposure. Poor social skills can also be the result of social anxiety, which may interfere in the ability to communicate effectively. If this is the case, the patient may indeed have the necessary skills, but could benefit from anxiety management to help them use their skills more effectively. Some patients with certain diagnoses, such as schizophrenia or Asperger's syndrome, can also benefit from learning appropriate social and communication skills. Communication skills training can include learning how to initiate conversations, engaging in chit-chat, making topic transitions, and learning to make and respond to requests. Communication skills training can also include teaching nonverbal skills such as pacing, rate of speech, having appropriate eye contact, knowing what appropriate personal space is, modulating tone of voice, and reduction of frequency of ums or ahs in the conversation. Listening and reflection skills can also be taught and modeled for the patient. And empathic responding can be worked on with the patient, as can job interview skills. Remember that these skills can be worked on in the session, and then the patient can be asked to practice the skills between sessions. The following slides can be used as handouts for your patients who are working on learning to improve their communication skills. When I begin to work with a patient on improving their communication skills, I first highlight the various styles of communication and initiate a conversation about what their style is and what style would work better for them in their lives. In this slide, you can see that we compare the aggressive style, the passive style, and assertive style. As an aside, it goes without saying that as the therapist, we want to be clear about these distinctions and recognize if our own style is problematic. It is difficult to help a patient if we don't possess the appropriate skills ourselves. Aggressive style includes fighting, accusing, threatening others, and not regarding their feelings. We discuss how there may be temporary short-term advantages to this approach, such as that others will rarely push you around, but the clear disadvantage is that others will not like you or want to be around you. With a passive style, you let others push you around. You don't stand up for yourself and are generally compliant regardless of how you feel. The short-term advantage may be less immediate rejection, but the problem with passivity is that you can be taken advantage of and then can store up resentment and anger, which most likely will not be beneficial for the relationship. With an assertive style, you can stand up for yourself. You can express your true feelings and tend not to let others take advantage of you. You are also considerate of others' feelings. There really is no disadvantage to this approach. The benefit is that you are more likely to be heard while being respectful to others. You act in your own best interest and do not feel guilty or wrong about it. Each one of these points can be discussed and practiced with the patient. As we discussed, it is important to collaborate with the patient about which difficulties he or she would like to work on and use real-life examples and scenarios to construct a plan for practicing the following skills. The patient can work on practicing standing up for his or her rights in such a way that the rights of others are not violated. He or she can learn to express personal likes and interests spontaneously. The patient can practice accepting compliments or disagreeing with someone or asking for clarification. The patient can also be encouraged to practice setting limits or saying no. He or she can be encouraged to practice being in a variety of social settings with the goal of feeling more comfortable and relaxed. The patient can also practice giving his or her own opinion. The goal can also be to help the patient foster the belief that they are equal to others. The following 2 slides are nice handouts to review with your patient as a guideline for how to work on furthering one's assertiveness skills. Using the acronym LADDER, L-A-D-D-E-R, we encourage the patient to look at their rights, what they want or need or feel. We try to help them define their goal for communication. Next, we work on the skill of arranging a mutually agreeable time and a place for a conversation. We then help the patient learn to define the problem or statement that they would like to make as specifically as possible. We work on just stating the facts and making a clear request or statement. Next, we work on describing feelings so that the other person can understand your position. We use I feel statements instead of you statements. Using I feel statements minimizes the possibility that the other person will become defensive. For example, saying I feel hurt versus you hurt me. It is very helpful to be specific. For example, by saying I feel hurt when you ignore my wishes about where I would like to eat tonight. We also work on the skill of being able to express a specific request in an assertive way. For example, by saying, I would like to go to a French restaurant tonight. Positively reinforcing the other person can be a helpful skill to work on as well. You may want to highlight the benefits of mutually respectful listening by reminding the person of how the outcome of an interaction has gone well. Similarly, during a negative interaction, it is reasonable to assertively let the person know what the negative consequences could be. For example, if you don't give me an accurate time when you will be home, then I will not cook and keep the food warm for you. When you have a valid point, clarifying your position and following through on your decision is an assertive response. This slide is a nice handout to give patients to review when they are holding on to some faulty assumptions that are interfering with their ability to appropriately communicate. The following are some common mistaken assumptions that often underlie a passive individual's hesitancy to be assertive. For example, it is selfish to put your needs before others, or it is shameful to make mistakes. It is best to keep your differences in opinion to yourself, especially with authority figures. You should always be flexible and adjust to others. Or asking questions reveals your stupidity. Or you shouldn't take up others' valuable time discussing your problems. Or if you don't accommodate to others, they won't like you. The following are additional tips to help the patient learn assertive communication skills. It's helpful to try and shift your goal of communication from the other person must validate what I am saying for this communication to be worthwhile to if I am clear and direct and do a good job with my communication, then I've done what I set out to do. Try and think of the other's positive acknowledgments as the icing on the cake. It's a good idea to practice assertive communication with the least threatening person first and build up to the people or situations perceived to be more threatening. Make sure to have a plan for when, where, and what you plan to say. Rehearsal is always helpful when you are working on a new skill. It can be very helpful to use a thought record to analyze what thoughts or beliefs are triggering your anxiety or prompting you to avoid an interaction. Make sure to practice, practice, practice. Practice in session and in everyday life. Patients with social skill deficits can benefit from paying attention to the following things that the therapist can point out and work on in the session, and then have the patient practice between sessions. Patients can learn to be aware of facial expressions, including noticing if they're smiling, frowning, grimacing, or not showing any affect. They can work on giving more or less eye contact. Noticing posture and body position can also be beneficial. Is the patient slumped or hunched? Does the patient look worn out or tired? Is the patient grooming adequately? Is he or she clean or dressed appropriately? In conversation, does the patient show interest by nodding or taking turns in the conversation? Does the patient always talk about himself or herself? Are they regularly negative or critical of others? Similarly, does the patient regularly whine or complain? Does the patient seek reassurance from others too much? As a therapist, it's our job to help the patient see all the variables that could be interfering in their ability to make connections with others and communicate reasonably in their day-to-day lives. Role-playing in the session is a form of behavioral rehearsal to help the patient practice social skills. Therapist and patient collaboratively identify a target skill to work on, such as initiating conversation or saying no, or making a request, or asking someone out on a date. The appropriate behavior can be modeled and practiced in the session before real-life attempts are made between sessions. If possible, it can be very helpful to videotape role-play interactions so the patient can see problem areas and work on modifying them. Videotaping also helps the patient review the progress made over time.